Welcome to our Equality of Opportunity in Action series. I'm Katie Mahoney, Vice President of Health Policy here at the U.S. Chamber of Commerce. This action series is part of our Equality of Opportunity initiative, which is made up of more than 500 state and local chambers, associations, and businesses from across the country, with the goal of advancing private sector policy solutions to help close race-based opportunity gaps in education, employment, entrepreneurship, criminal justice, wealth, and health. Driven by data and informed by conversations, the initiative convenes key stakeholders to explore the issue of race-based inequality and advocates for sound policies and solutions. I'm glad you've joined us for this important discussion today on addressing maternal healthcare disparities. Black, American Indian, and Alaska Native women are 2 to 3 times more likely to die from pregnancy-related causes than white women, according to the Centers for Disease Control and Prevention. Disparities have persisted over time and across age groups and remain present even among groups with higher education. The pregnancy-related mortality ratios among Black women with a completed college education or higher was 1.6 times that of white women with less than a high school diploma, and 5.2 times that of their white counterparts with a college education or higher. Today, we'll hold conversations with private and public sector leaders to discuss the business community's role in addressing disparities in maternal health, solutions for advancing health equity, and opportunities to work together to improve outcomes. And now I'd like to introduce our first 2 speakers, Congresswoman Lauren Underwood, who represents Illinois' 14th District, and Latricia Boone, Vice President of our Equality of Opportunity Initiative here at the U.S. Chamber of Commerce. We look forward to the discussion on the proposed Black Maternal Health Momnibus Act.
Thank you, Katie. Hello, everyone. I'm Latricia Boone, Vice President of the Equality of Opportunity Initiative here at the United States Chamber of Commerce. In just a moment, we'll be hearing from Congresswoman Lauren Underwood, who represents Illinois' 14th District. Representative Underwood has been a leading advocate for a stronger healthcare system, bringing awareness to issues related to maternal health. She is the first woman, the first person of color, and the first millennial to represent her community in Congress. She is also the youngest African-American woman to serve in the United States House of Representatives. She is a co-founder and co-chair of the Black Maternal Health Caucus. Prior to her election to Congress, she was a registered nurse. Congresswoman, thank you for taking the time to join us today.
Thank you so much, Latricia. I'm so glad to be with you.
I would just want to jump right in. And again, thank you. We are honored to have you and looking forward to this conversation. With your background working in healthcare, you bring a unique and authentic perspective to the issues that we're talking about today, and particularly to your policymaking role. Can you share more about why the issue of maternal health is so important and how communities of color, particularly Black women, are being impacted?
Well, we have had some longstanding health disparities in our country, but we've seen that, yes, maternal health is one where, Black birthing people are 3 to 4 times more likely to die from pregnancy-related complications than their white counterparts. This is a disparity that's been around my entire lifetime, and I'm 34 years old. And for every death, we have 70 near misses. And so when I think about the opportunity that we have to make a difference, when I think about the opportunity that we have to save lives, I think that in many respects, we're long overdue to take this action on maternal related deaths, particularly in communities of color, because the majority of these deaths are preventable. We know what the solutions are. We've just not necessarily seen the political will or the prioritization of this population when we think about policymaking circles. And so, this is really our opportunity to make a difference.
Yeah, thank you for stating that. And it's interesting, you talk about it being a long-standing issue and one that, thankfully, we have folks really on the front lines now trying to bring awareness, but also action to. As you think about this, why do you believe, I almost feel silly asking this, but I think it's important to frame for our audience that we as a country really need to make critical investments to improve health outcomes for all?
Well, we have to take action because things will not just change on their own. We have an opportunity to intervene. When I think about this disparity, it persists. So that means education status, where that would usually mean highly educated birthing people are less likely to die. That's not the case for Black birthing people. Having health insurance, getting prenatal care, right? Those things are not protective factors in the way that we might usually anticipate. And so this is not a problem where kind of like trickle down solutions are going to make a difference. We have to be specific, we have to be targeted, and we have to be aggressive if we are going to end this disparity. When we talk about maternal mortality or maternal deaths, because of this disparity that we see among Black women and Indigenous women, the United States leads the industrialized world in maternal mortality, right? So if we can solve this problem, we help improve healthcare and the health status for all birthing people. And I think that that's a very worthwhile goal. And certainly when we think about the investments that we make, they're shared outcomes.
Yeah, specific and targeted. I really love that because I do think that we talk about that in a business context so often, but even in the context of what we're talking about, our healthcare system, which at the end of the day, to your point, adds value in so many other areas of how we think of ourselves as a leader globally. So I really appreciate hearing that. As co-chair of the Black Maternal Health Caucus, you've really helped to spearhead the Black Maternal Health Omnibus Act 2021, which is focused on solutions that help to end our country's maternal health crisis. Can you talk a little bit more about this comprehensive package of bills and really what they aim to address specifically?
So the Black Maternal Health Omnibus Act is a comprehensive suite of bills. We have 12 bills aiming to end our nation's maternal mortality crisis. But what it doesn't do is that it's not duplicative. So for example, we've had some longstanding initiatives, bills that are attempting to expand postpartum Medicaid. That's not in the Momnibus. What the Momnibus is looking at are issues like social determinants of health, housing and transportation, nutrition, and how some key investments there can help save moms' lives. We have the Moms Matter Act, which is addressing mental health and substance use disorders, which are becoming a leading cause of maternal death in this country. We have a bill specifically aimed at helping our veteran moms. Why? Because the VA is a federally run healthcare system, and we have an opportunity to reduce the disparity that we see even within that healthcare system. We have legislation related to COVID-19, because we know the data has shown us in these last 15 months that we've been in this pandemic that there's this dangerous combination of pregnancy and COVID where, particularly women of color are more likely to get severe COVID. And when they do, they have really negative birth outcomes, right? And so we've taken those early experiences in the pandemic, crafted legislation to help give us the tools to increase maternal vaccinations, for example, and save lives in the pandemic context. The last one I'll spotlight is our climate change related bill. We know that extreme heat and air pollution will lead to a negative birth outcomes for both mom and baby. And so we have a bill specifically targeted to help increase the resources that folks would receive in order to be able to fight back. So we're trying to fill the gaps. We're looking at the data and the evidence, trying to make sure that we are data-driven policymakers, right? But also in a way that's inclusive and bipartisan so that we can save lives.
Yeah, you said a lot of things there that really just prompt me to think about our work in a deeper way. You talk about some of those intersections and the fact that there's so many ways or things that are impacting that aren't just isolated to health.
That's right.
When you think about, the various partners and key stakeholders that you've been working with to bring awareness to these issues and really help advance those policy solutions that are part of this package of bills, can you share more about how you've engaged the business community this far and where you might see greater opportunities for a business to lean in from a partnership perspective, whether it's a company that's in the health industry or companies that are just looking at this from the perspective of an employer?
We've been really pleased to be able to partner so closely with industry leaders. And when I say we, I mean the Black Maternal Health Caucus that I co-chair. We've consulted with key private sector stakeholders in drafting this Momnibus bill, the comprehensive suite of legislation. And so it's really led to the largest and most diverse coalition of endorsing legislation of legislation of this kind, right? So when we look at the groups and the companies that have engaged, we've not seen this kind of cross-sector come together before on a healthcare bill like this. We've collaborated with the Blue Cross and Blue Shield Association to get their real-time data on maternal health outcomes, and that lets us inform evidence-based policy solutions. That's really important because the federal data is often lagging maybe 3 to 4 years behind. And so when we can work with like issuers, for example, private insurance companies, and they help us out, we're able to get a more real-time snapshot, which has been really important, for example, in the COVID context. We've worked with AHIP, America's Health Insurance Plans, the Federation of American Hospitals, and other healthcare industry leaders to push for the expansion of the postpartum Medicaid coverage expansion. And then we've been engaging in these really robust conversations with companies that have been looking to leverage their own expertise and utilizing their own services in order to address maternal health disparities. So I'm thinking about rideshare companies like Uber and Lyft that want to make sure that new moms can get to their postpartum visits. The diaper companies like Huggies, who want to make sure that pregnant people have the essentials that they need to care for their growing families. And, you know, one of my favorite things about our Black Maternal Health Caucus is that we've really served as a maternal health hub, right? We're connecting the private sector companies that are looking to support this cause with local organizations. And so then they're able to foster these partnerships that expand the reach of those organizations and lead to really critical initiatives that save moms in their communities across the country. Now, those are a few examples that are both directly within and outside of the healthcare space, but it's, I think, a good snapshot of the leadership, the bold leadership that's being displayed that enables us to have these kind of comprehensive solutions advance within the Congress. And it's those partnerships and these solutions that will be needed to end this crisis.
Yeah, that's powerful. And I think to your point, the partnerships and the bold leadership and the innovation that you just shared with us, those examples are really how you make progress and move things forward. And to that end, I mean, you've achieved a significant milestone with the bill in June when the House Energy and Commerce Subcommittee Subcommittee on Health announced its consideration of 2 additional bills included in the Momnibus Act. Can you tell us more about that and how you anticipate this legislative process moving forward?
Well, we're really excited that the Momnibus has so much momentum both in the House and in the Senate, but you're absolutely right. Energy and Commerce advanced the Maternal Vaccination Act, which is led by Congresswoman Terry Sewell, and it just passed the Energy and Commerce Committee, the full committee, with unanimous bipartisan support. And then we had the Data to Save Moms Act, which is led by Congresswoman Tracey Powell. And that also passed the Healthcare Subcommittee with unanimous bipartisan support. We have the Social Determinants for Moms Act, led by Congresswoman Lucy McBath, that EMC just considered in a legislative hearing on their Healthcare Subcommittee. And so, you know, listen, we are leaning in. We are trying to move these bills individually through the committee process while also looking for opportunities to advance the entire Momnibus as a whole. We know that we cannot solve this crisis without a comprehensive approach that the full Momnibus represents, but we also respect regular order in the Congress. And so we sort of have a both-and strategy going on.
Yeah, that's great. That is awesome. So, you know, coming back a little bit to the U.S. Chamber of Commerce and the work that we're doing here, our Equality of Opportunity Initiative is really focused on advancing private sector solutions and best practices, in addition to policy action and some of what you just talked about as it relates to closing race-based opportunity gaps. Given the broad scope of the Momnibus Act, what do you see as the larger role of the business community in addressing maternal health and improving health outcomes in meaningful ways? You shared some examples earlier of ways that folks are leaning in and you're partnering, but as we're talking or hearing from our larger group and our larger network, just share a little bit more about ways that you see our member companies and others that are engaging with the U.S. Chamber really leaning in to support this work.
Well, as we've seen with the pandemic, public health crises, whether it's COVID-19 or maternal mortality, they require not only a whole of government response, but really a whole society response. And that's what the Momnibus would provide. One section of our Momnibus would establish an interagency task force with representatives from federal agencies and community-based nonprofits and private industry to develop comprehensive strategies to address social determinants of health during and after pregnancy. And so in addition to including these industry partners on the task force, this interagency task force, the Momnibus also provides opportunities for the private sector to engage in the development of a perinatal care alternative payment model demonstration project. It has opportunities to identify hospitals that are interested in establishing respectful maternity care compliance programs. And those are important because they allow us to collect better data on the prevalence of bias and discrimination and racism in maternity care. And it really just fosters accountability, which is something that in many ways we can improve on. And then it also industry can help us develop and to disseminate digital tools to improve maternal health outcomes in underserved areas. There are so many opportunities for employers to lead on the issue of maternal health outside the context of the Momnibus or any other federal legislation too, right? Like everything is not, going to be dictated in the text of a bill, right? And so we encourage companies to think about leveraging their own data to provide the government and researchers and the public with more comprehensive and timely understanding of the maternal health outcomes across the country. Companies can look for opportunity to bring their own products and services to pregnant people and new moms. They can partner with and support community-based maternal health organizations within their own area to ensure that their neighbors, right, have the resources that they need to carry out the important work with and for pregnant people. And then I would also just encourage companies to continue to advocate for policies like the Black Maternal Health Momnibus Act, both in public settings like we're doing today, but also in conversations they're having individually with lawmakers. Because together we can take the bold action that will be required in order to save moms' lives, end these racial and ethnic health disparities in maternal health outcomes, and achieve true equity and justice for all.
Yeah, thank you so much, Congresswoman Lauren Underwood. I think, the things that you just lifted up are the things that we are very proud of at the U.S. Chamber of Commerce in terms of how companies have been able to, even during our global pandemic and COVID-19 and everything we've been dealing with, been able to step up, lean in, support community, bring innovation, use data, all of these things that we know we have an opportunity to lead and unite around have happened. And so really appreciate the opportunity to hear more from you about this. I'm excited for us to move into the next part of our conversation. But again, thank you so much. And we are looking forward to our esteemed panel to dig in just a bit deeper on some of those disparities we just talked about and how we can be solutions driven in this work. Thank you.
Hi, thank you so much, everybody, for coming today and for joining our panel. I am Laura Casisto. I'm a reporter at the Wall Street Journal, where I do not generally write about health, but I wrote a story this spring about maternal health and postpartum care in particular after I had my own son almost exactly a year ago and spent 2 weeks at home struggling to get treatment, struggling to get someone to listen to me, feeling very helpless, everyone telling me, this is normal. This is what it feels like to be a mom. You're just tired. And this became an issue that was very dear to my heart. And after I wrote that story, I heard from really hundreds of women with similar experiences, and it really touched me. And so I'm so grateful that all of you are here today. And I'm going to give you a quick introduction of our panelists, who I'm very, very excited to talk to about this topic. So first of all, we have Dr. Alan Fishman. He is a specialty medical officer for maternal fetal medicine at MEDNAX, a national medical group where he leads a group of over 250 maternal clinicians who specialize in working with women who have high-risk pregnancies. He has a particular focus on telehealth, electronic records, and technology innovation projects, and has some really exciting ideas he's going to talk about today. So I'm really glad he is here. We have Nadia Primus. She is the manager of quality and safety improvement at Hackensack Meridian Health. She leads the network's improvement initiatives, reducing the cesarean delivery rate and 8 other maternal health metrics, overseeing quality improvement at all of HMH's 13 acute care hospitals. She also told me that her mom calls Nadia the one with the dog because she is so in love with this work that she has time for little else. And I'm so also excited to talk to her about it. Next, we have Tracey Powell. She is a long-standing patient advocate with the Preeclampsia Foundation since she too had a near-death pregnancy experience. She currently serves on its Racial Disparities Task Force and is Vice President of Programs with the New Jersey Family Planning League, a nonprofit organization committed to providing access to quality family planning and related health services, regardless of identity, income, or insurance status. So I wanted to start out and ask all of you if you could talk to me about the thing that you have observed in your work in this area. You all bring a sort of huge wealth of experience. What have you observed? What is the sort of one thing that you could think could most change maternal health outcomes, could improve disparities? And if it hasn't happened yet, what is the barrier? Why hasn't it? I'm going to start with Nadia.
Thank you, Laura, for the opportunity to participate in this space and discuss this very important topic. As Hackensack Meridian Health Quality Improvement Manager, I work with all of our birthing hospitals, clinical leadership, and our frontline team members. In my role, I'm able to take both a hilltop and granular view of the disparities in maternal health, looking at the outcomes and exactly how can we improve those things. As a quality improvement leader, I'm in a position to lead compassionate and respectful care, inherent to the dignity and worth of each individual person that we see. One of the biggest ways we can impact disparities in maternal care is by genuinely listening and centering our care around all aspects of each mom's life. This is a fundamental shift in the way we practice medicine. I believe we're making progress, and it's reflected in our outcomes. At HMH, we have 10 birthing hospitals, and we deliver over 17,000 babies each year. So every new practice we implement, it affects hundreds and thousands of moms across the state of New Jersey. We also track each hospital's outcomes. Leveraging our data analytics, we're able to drill down to zip codes, race, socioeconomic status. This gives us a granular view of the patients that we serve. We look at everything we got right and the things we didn't get so right. And from this, we're able to chart improvement work at each of our sites.
Nadia, I remember when we spoke earlier, you had talked to me about how you put moms at the center of your care, and how you talked to me about kind of putting up the pictures of moms so people could see. And I'm wondering if you could talk about that. I thought that was really sort of touching.
No, thank you. So in January, our network led a maternal health conference for all of our hospitals and team members across the network. And to really get a clear understanding of what harm is, we put up, initials and a quick blurb of each mom who came into our care, where something didn't go quite as planned. And there were instances where, although everything, went right according to plan, something, happened, and we're monitoring harm, not only physical, but emotional. So those were highlighted in a different font, so everyone can really understand we touch so many lives, and although there's so many lives that we touch and we do great things, there's still harm out there. And that really cemented the message to all of our team members, because we have a ways to go when it comes to leading the charge to prevent harm to our patients. So we received a lot of positive feedback, because then it was not just a medical record number, but we identified that these are people, these are moms who are, delayed in coming home, who are now, faced with additional challenges as a result of something that could have possibly gone wrong within, their care.
So I think we now also have Dr. Juliet Nevins, who's been able to join us. So I'm going to welcome her as well. I'm so glad that she was able to figure out her technological issues because I'm very excited to hear from her. Dr. Nevins is really a kind of leader in this space, and I find has sort of a real knack for talking to and about patients in a way that is really empathetic. And she is also the Clinical Solutions Medical Director at Aetna, a CVS health company, where she serves as a member of the Women's Health Committee. So Dr. Nevins, I'll just throw you right in and ask if you can talk a little bit about this first question I had, which is, what do you see as the kind of biggest, the one thing that we could do that would most improve maternal health outcomes, would most sort of heal these disparities? And what have been the sort of barriers to that? Why has that not happened yet?
Right. Whenever I talk about, well, first of all, hello, everyone, and thank you for the invitation to speak at this event and join this conversation. But to dive right into the question, I always talk about two things, really focusing on the physician-patient dyad and making sure that there's some purity there with respect to physician training in terms of understanding one's own bias. And certainly on the other side, focusing on health literacy and health education so the pair can communicate and work together effectively. So in addition to that, certainly there are systemic issues that we have to address from the bottom up, if you will, such that we can remove the barriers that are a function of, racism that is sort of cemented and baked into our system. And that will take some work and some really dedicated, focused attention.
So I will ask Nadia, maybe if you want to jump in and give me what's the thing that really bothers you? What's the thing that you would like to wave your magic wand and change if you could, and why has it been difficult?
I would say.
Oh, sorry, not Nadia. Sorry, Trayshawn. I won't make you answer the same question twice. Trayshawn, go for it.
Nadia, feel free to wave your magic wand. For me, when we talk about ways that health systems and insurance companies can really improve care, we talk about trauma, right? And trauma is a very scary thing, and trauma really stays in the body. And as Dr. Vesselband de Cloak reminded us, is that the body keeps score of trauma. And so for me, my daughter was born January 3rd, and she passed on January 5th. That very next same year, we welcomed a baby girl at the very same hospital where the trauma occurred. So when I think about the magic wand, I think about what postpartum care looks like. And postpartum care is very important for hospitals to provide not only the basic follow-up postpartum care, but trauma-informed and culturally and linguistically appropriate trauma postpartum care. Grief does not look the same for everyone, but it doesn't mean that the new mother isn't grieving. She may need space. She may not follow up with hospital social workers, but hospitals should equip their staff with this very important engagement. This important engagement was necessary for me, and what could be a simple phone call could really save and impact a mother's life and give her the support that she needs when she's even thinking about trying again.
And I'm wondering, I sort of had experienced similar issues with this, and one of the things I found was I felt a little lost in the hospital system. I had my doctor who was taking care of my physical health, but there was a mental, emotional component to what happened to me. In my case, my baby was okay, but I didn't see my newborn baby for 8 days, and there was a lot of trauma around that. I'm wondering if you could talk about who in the hospital can be or should be sort of in charge of making sure that the mom's sort of mental health is taken care of as well, that trauma is not lost in the sort of physical drama of what's happening. Anyone can jump in on that. It could be Trayshawn or anyone else.
Yeah. If I may, so, I think about the question, and I'm going to sort of refer back to our sort of back to breast campaigns, where it required sort of leadership to do the simplest things, right? Like not giving the baby a bottle, discussing the mother's preferences prior to feeding the baby, removing things that in the room, physical items that would necessarily pose barriers to breastfeeding.
So I think about the question, and we are so siloed, and we are so married to our workflow and our role that the very thing that the mom needs to see a baby sometimes gets missed. And I don't think it's nefarious, it's not intended, but again, it's a structural problem where we're not set up to allow the mother and the baby to necessarily bond, and no one's necessarily thinking about it. So, I've had a C-section. I'm unable to, to move around. The baby's upstairs on the NICU. If I don't think to ask, if I'm afraid to ask, if I'm unable to ask, is there someone who is going to do that for me, who is going to be my voice? And I think that comes from leadership. That comes from someone at the top thinking about these small, very important steps and implementing a person or a workflow or messaging to the staff such that, you don't go 8 days without seeing your newborn baby, which is a little cray-cray. But, like I said, I'm very much into structure, and structure does not have to be sort of without sentiment, if you will, or enthusiasm. We can bake in joy and laughter and humanity in our hospital systems. So I'll stop there so that others can answer the question as well.
Yeah, I think I want to make sure I don't leave out Dr. Fishman, and I'll give you the magic wand for a moment, and you can kind of tell me what you would like to fix about how we handle maternal health.
Sure. Yeah, I don't know that there isn't a magic wand and there isn't one simple solution, but I think the points that people are making, I would broadly define as really barriers to access care. And there's lots of different ways to think about barriers and the problems of accessing care. I think a lot of people think of, there's a problem of accessing care as can a patient get a physician? Do you have insurance coverage? Is there a payer? Is there something there? But there's a lot of access of care that's beyond that. There's, once you have a doctor, can you get to your appointments? Can you, do you have to make a decision if you have food insecurity between putting a meal on the table and staying at work versus going to an appointment? Are there issues with, transportation, the economic issues of getting there for people that are experiencing financial difficulty to get that, even if they have a care provider, even if they have it. We all face access issues, and we've seen that during the pandemic kind of accentuated, but I see it every day in the hospitals we all face a lack of access when we don't have adequate nursing staff in the hospitals, when we don't have adequate providers, when we've seen burnout providers leaving, or the volume is so high and there's not adequate number of providers to provide those care. These are access issues, and it affects all of those things. While it affects throughout the universe of healthcare, it certainly disproportionately falls on people that are at the lower end of the financial totem pole, at various ethnic, racial, demographic groups that don't have that adequate coverage. And when you find public hospitals that have very large percentage of Medicaid and government payer, they are in general going to be more stressed and more staffing issues. So I think ways and strategies that we can find, while access really isn't one thing, there's a million different ways to approach it, from policy, from technology, from innovation, from all the things you're hearing. But I think that in the broadest scheme, I would say that would be the magic wand would be magically creating enough care providers and system redundancy and access to care for everyone that needs it.
And, I had sort of asked in the question about obstacles, and I wonder this particularly with what you're talking about, who do we need to kind of push on for this? Is it that care providers are sort of reluctant to bring in technology? Is it that patients really want to sort of see a doctor in person? They like the way things have done. Is it that insurance companies aren't really set up for innovation, or health systems, or where are the kind of points that we need to sort of push on if we were going to try to kind of have that innovation you're talking about?
Yeah, I think that all of those things. I think in the innovation space, there's a lot of opportunity. whether it's Medicaid looking for some innovative projects to say, well, we're having grants and doing projects or looking for projects that we'll partner on, whether it's individual employers, and we've had some success working with employers for some pilot projects that kind of touch on this area. These are all opportunities for us. We are specifically looking within telehealth has given us, if you will, a way to go back a little bit. It's not as new of a model. It's in this country we had healthcare that was provided in the community. We had house calls. We had things like that in the 40s and 50s and even in the 60s. Well, telehealth kind of gives us a little bit of a technological way to do that in the 21st century. To provide, how do we provide care for patients in their environments? Not be disruptive to them. Not remove them from they're in childcare, they're at work, wherever they are in their lives. How can we come to them? How can we do that? One of the big barriers to moving forward in telehealth, and we were very interested and very, very forward into this space prior to the pandemic, was that we just couldn't get paid for it. None of the payers covered it. Medicaid didn't cover it. Most of our payers didn't pay it. So we could do it. We had the technology to do it, but then we didn't get paid for doing to do the service. Suddenly with the pandemic, that got covered, and that obstacle went away, and we've kind of embraced that in a lot of ways. So there's good and bad from everything going on, but that took us to another level to say, this is a way, and guess what? There's huge patient demand. There's huge desire to say, once we go this way, patients say they don't want to come back into the office. They just want to, this is fine. This is working great for them. And that has led us to sort of get into the prenatal space, doing the same thing. We've partnered with a technology company that has a device where we can provide remote fetal monitoring and vitals monitoring. And we're looking to how to redesign prenatal care in a way where we can provide better care and be less disruptive to patients. And when I think of this, the applications go across the spectrum. It certainly goes to people that have trouble getting in, or trouble leaving their place of work, or leaving their home and their childcare duties, and say, if I want to go, I have to pay for an Uber or pay for some transportation to get there. I have to pay for childcare. I have to go sit for half a day in a clinic in a waiting room for a 20-minute visit and have all this frustration. Instead, we're actually able to bring that to them, and we're actually able to monitor them in a better way. But there's a cost for the device. There's a cost for this. So we pilot, how do you partner this? How do we achieve this? So I don't mean to say that this is a universal solution for every place and every community, or the only way to approach it. But I think there's tremendous opportunity that's exciting, that we are bringing now. It's happening.
I wanted to just, if I may, jump in and emphasize, not to be a Debbie Downer, the challenge, because the pandemic has certainly accelerated our willingness to use telehealth. But when you talk about, socioeconomic determinants of health, one of the things, I live in New York, that I have learned and I've come to understand, and you touched on it, the cost of the equipment for the patient, understanding how to use it and how to access healthcare, logging in, registration. I mean, if nothing else, the school system and the challenges that they faced in New York with respect to the virtual learning space and getting students who live in certain zip codes up to date and up and running, it was very difficult. So I'm very excited about telehealth. I certainly see it as an access point. And just to echo your words, but I think we also have to be mindful that when we're talking about inequities and disparities, therein lies challenges as well, in terms of equipment and health literacy, in terms of how to use technology and the intersectionality between those two things.
Yeah, and I'd like to also respond to that. I 100% agree. And that my point is, there's nothing that I know of that's going to fit all groups everywhere. And I'll give you a very clear example from our national group. We have some groups that are in areas where they work very closely with Indian Health Services Reservation. There are places where they don't even have stable internet. But what I find is, in the vast majority of our populations that are rural or urban, everyone, I'm not going to say that, the vast majority of people have internet, have a device that they can get on. There are varying degrees of how comfortable people are or what they can do or how you do it. We have learned that we need to have a navigator. We have to have someone help, but we have had good success with it being able to do it. But this goes to small scale pilot. How do you roll it out? Where are the costs? Who's covering the costs? Certainly Medicaid isn't jumping in and covering those costs. We are actually piloting this in areas where we have an interest with business community. I'd be happy to talk a little bit more about that. But the opportunities there, whether it's grant space, whether it's way to focus on specific communities and do it. My approach when I look, I mean, I represent and work with a group that is across the United States. We have each functioning unit as a practice with a medical director. I can't tell them all what to do, but I do see commonalities and I do see things that are generalities. And where we see it in our system is this is a pretty good thing with a pretty high penetrance and a pretty good applicability to a majority of the population. And that's encouraging to me. It's something to work on.
Yeah.
I'm wondering, Trishan, we got a question from the audience that sort of really resonated with me that I thought maybe you could talk a little bit about. They asked, is there a way to look into giving moms a way to speak and be heard? How does one build the language and conversation around this issue with healthcare practitioners and administrators? I mean, this sort of touches on what we had kind of talked about earlier, but yeah, how do we kind of give moms a voice within these big hospital systems that I think are often very kind of intimidating and overwhelming to people? And also, how do we sort of give them the knowledge to be able to kind of spot problems in their own health?
Sure. I think as being a mom and also being a patient, it's very difficult when you're in big systems with hospital practices and big hospitals. I think in giving them the space to be heard, it's seeing different hospital practices. Where is the survivor's perspective? I think a lot of hospitals right now, the maternal health disparities challenge, the maternal health crisis, that's now what folks are talking about. And what we want to also look at is where is the survivor's perspective? Where is their voice? With the Promise Walk, and that's a signature event of the Preeclampsia Foundation. We serve many communities where survivors are survivors of preeclampsia, survivors of hypertensive disorders, have the ability to share their story, not only at the Promise Walk, but also online, share their stories with different survivor groups. Currently with the Racial Disparities Task Force, we sit on many different platforms in arenas where we try to make sure that voices of the Black and Brown communities are supported, are encouraged. But what I do want to mention is that when hospitals want to change their practice, when hospitals want to implement trauma-informed care, culturally specific care, we look to have the survivor's perspective, the survivor's voice.
Nadia, I'm wondering if you can talk a little bit from the other side of things, from a kind of doctor and a kind of provider perspective. I think it can be very difficult to sort of talk about when things go wrong. It's really hard for me in my job to have to run a correction. I really hate it. And they make me fill this huge form and I get very defensive. And I know that can be true in hospitals too. And I'm wondering if you could talk about also creating a culture where physicians and other providers are able to sort of talk about when things go wrong and learn from that.
Yeah, Laura, I love that question because it allows me to speak to the why and the how. I'll start by saying our mission statement says that HMH is dedicated to transforming healthcare and to be recognized as a leader of positive change. This is in alignment with our HRO journey. Every 2 weeks, there's a clinical OB safety call. On this call, we have our clinical leaders and staff members across all of our birthing hospitals. This forum provides an opportunity to describe any event that didn't go according to plan. Anything at all, whether it's a large or a small event that somehow impacted the patient care. On this call, we've been able to foster a blame-free environment. I mean, folks are very anxious to get on this call and talk about what has happened at their hospitals in the last 2 weeks. And during this time, we're able to leverage the expertise of everyone across our hospitals. And this comes from our smallest hospitals that delivers about 500 babies a year to one of our largest hospitals that delivers thousands of babies a year. So in this firm, people are able to leverage on the expertise of each and every one within a large healthcare system and learn from those mistakes. So those things are not reoccurrences at any of our organizations. It's a very lively bunch of folks on that call. Sometimes it gets, a little too active as everyone has an opinion and everyone wants to share, so much of what they're seeing at their different sites. And we're really able to tailor the learning that's being shared and right size it to each organization. Because although we're one network of hospitals, each hospital is different in its own unique way. So being able to right size improvement at each hospital is very essential. Storytelling has also proven to be very effective. At the start of each meeting, a patient's safety story is shared. Here, it can be a near miss, a good catch, or even an adverse patient outcome. But then we break down each of those stories with a lens of bias, exactly where the error occurred, and we offer solutions. And that's shared across the network of hospitals. So like I said, every meeting must start with a safety story. And exactly how do we ensure that that does not happen again and again at each hospital? Because we're never going to live long enough to go through and correct all of our mistakes. So really being able to create a culture where we're really able to share when things go wrong and learn from those as an organization, I think is very key to being able to improve our outcomes, not only within the hospital, but it translates into the largest state of New Jersey.
And I'm wondering, something that really interested me when we talked earlier was, this is an area where I think of change as being very hard, as being very slow, as being quite incremental. And you talked about wanting to kind of catapult change, of wanting to have this kind of really sort of significant improvement in outcomes. And I'm wondering if you can talk a little bit about what it means to do that, and also kind of if you've been able to start to see progress, or what the kind of timeline for seeing progress might look like.
Yeah, so as I mentioned, HMH, we're the largest hospital system in New Jersey, and it all depends on, what story you read. When it comes to our maternal health outcomes, we rank 47 or 48. And because we're such a large organization, I really do believe that getting it right at Hackensack Meridian Health will definitely be able to catapult us out of that very low ranking in the United States. Any change that we implement, that's going to touch thousands of moms and thousands of families. So yes, really being able to see those changes, and it's reflected in our data. When we're looking at where we started years ago and where we are now, we are making a huge impact. So I'm very hopeful and optimistic. I'll give you one small example. In 2019, our C-section rates, those were over 25%, straight across the board. And now year to date, we're about 18%. The national average is 23.9%. So we're well below that. So I really do believe that our improvement strategies, it's leading to positive change. So I'm going to remain hopeful and optimistic.
I'm wondering if we can talk a little bit about, we had an audience question about this, and Congresswoman Underwood talked about it, that the provider groups, health systems, plans, sponsors, insurance companies, they have access to this useful health data, she said, often before the government does. And Dr. Nevins, I'm wondering if you can talk about how we can use this data to measure and access utilization rates to improve outcomes for patients. And also, I'm wondering how we can make sure that data is not prescriptive, that data sort of gives us information, but that we also give physicians room to sort of trust their own instincts and experience. That's a big question, but I'll let you maybe take a crack at it.
So I'll break it up into parts, because as I think about the Momnibus Act, I sort of pair that with steps that are actively being taken by my company and by other entities. So in terms of, you had asked a question about giving the mother's voice, we have the tools, and to circle back to our conversation around technology, to support mothers by covering doulas. We want them to have a voice, but these moms, they're not well, they're exhausted, and they need an objective person standing by them who can speak on their behalf when no one else in the system, thinks to ask, well, she hasn't seen her baby in 8 days. How can we make this happen? So that's something that, providers and health plans can help to facilitate. We have electronic medical records, and I'm really excited, and I won't name, the one that I'm thinking of, but there seems to be more uptake. And one of my grievances was that we have electronic medical records, but none of the systems necessarily talk to each other. There's no easy exchange of information, which is very important when you're trying to prevent patients from slipping through the cracks. In certain zip codes, you do have people going from hospital to hospital. You have redundancy of care, and then you have care that's not being provided because the information is fragmented and the patient is unable to sort of report carefully and completely essential information. And so, there's a matrix that we can certainly create. We have information that will allow employees to speak on behalf of their patients, implement wellness programs on behalf of their, employers, implement wellness programs on behalf of their employees, and ask tough questions and make tough demands in terms of what they want. The C-section rate reduction that we've seen in the last few years, and I think most of you on the call can attest to this, has been a function of big data, looking at the number, pairing that with reimbursement, keeping people accountable for doing a social or elective C-section prior to 39 weeks. And over the last 5 years, that all went down. So we can certainly use data to help the individual mom, to help the system, to help the employees who are trying to help their members and their cohort stay healthy. And in terms of not using the data as a straitjacket, if you will, I'll tell you, I had an induction a few years back. It wasn't working, so I sent the patient home. I thought everyone around me was going to have a seizure because I did something that I was, quote unquote, not supposed to do. But per my clinical acumen, this induction was not going to happen. And I said to the patient, you're going to end up with a C-section if we keep going. Nothing's wrong with you. The baby's fine. It's just not time yet. She agreed with me. She went home. She came back in labor 4 days later and delivered a beautiful baby. So again, that's an example of, we want the systems. They are useful, but we don't want them to sort of tie the hands of the physicians who are really trying to do what is in the best interest of the patient. There's an old adage, you're treating a human being, you're treating a person, not the numbers, not the data necessarily. So I'll stop with that.
And I'm wondering if we could ask, we have like a couple minutes left, and I think since we're at the Chamber of Commerce, Dr. Fishman, I'm wondering if you could talk about, a lot of these insurance plans, come through the employer, and I think a big part of what employer insurance plans pay for every year is maternity care, and I'm wondering what role kind of employers can also play in kind of pushing for changes to care, pushing for innovation, pushing for improvement.
Yeah, certainly. Like I said, we've had some experience, recent experience working with employers, large employers, particularly the ones that have their own healthcare or wellness programs set up. And one of the things that we're hearing and that we are interested in responding to is there's a level of dissatisfaction in many cases. Their employees love their own healthcare, the wellness programs that are set up on site. I happen to reside in Silicon Valley, and a lot of the large employers have really very significant and sophisticated wellness programs. the employees love to go to their own physicians in-house and seem to be very responsive to the kind of care they get and the way that care is delivered. Yet there's a dissatisfaction because they almost always send OB care out, and the experience of the employees tends to be they judge a lot of what they get as lots of time and a low value interaction. And so this has gives an opportunity to say, how do we partner and how do we look to address that? And I think I talked a little about the idea of a remote program, something that gives back the patients their time, whether it's time in their office, time in their home, time in their lives, but providing that care in coordination with the wellness centers, in coordination with on-site services that are available, minimizing disruption, data flow back and forth. As Dr. Nevins described, we have ways to link the electronic data from our EHR into there. So working with them on sort of data flow and working with this to find opportunities. So in the terms of saying, well, if I've got remote devices and that's something extra, I need that covered, there needs to be a coverage. We've worked with employees trying to provide that. In terms of saying, do they go and work with the insurers and the payers that they're working saying, hey, we like this, we want to do this. Can that become more mainstream and can it grow that way? And I'm hoping very much that it will. But finding that there are opportunities to say, how do we help, how do we work, and how do we find groups to do it? That doesn't address a lot of what you're talking about and what we've discussed with Momnibus and specific populations at risk and specific ethnic and demographic and racial disparities. Yet look at that and say, why can't that work? Why can't that work for saying, let's do a group? Do we have, whether it's a business group that will help fund or whether it's a grant providing group that will help fund, are we able to look at this and affect? And again, I view this as a million small steps. I mean, the smallest step is I'm going to get off of this call, go back, I'm on call, and I'm going to go make a difference in somebody's pregnancy. That's one small step. It's important to that patient. That's what I do, but that's not affecting the country. That's not affecting all populations. But it's something. It's what can we do? Can we find a few communities? Can we find ways to do this? And then from the success, how do we leverage that? We collect data. We publish data. We make not only sort of case studies and work with businesses that are interested and employers that are interested, then they tell two friends and they tell two friends. Then we publish. Can we show that there's an impact to care? Can we show what the ROI is? Can we get payers to cover this? Can we get Medicaid to cover this? These are all steps down the road. And I think there's tremendous opportunities to say, find whether it's clinician work groups for groups like ours, working with large employers that have the scale and ability and desire to say, how do we drive this? How do we improve that access? Because I guarantee you, even with large employers, there are employees there that with the cost of rent and the cost of running a family are living paycheck to paycheck and are making painful decisions every day about how they spend their time and how they spend their dollars. And this makes a difference.
Yeah. So I think we have only scratched the surface of this topic. I have not gotten to all of our audience questions. I have not gotten to most of my questions, but we have had a good discussion and I've learned so much and I know that our audience has. So thank you all so much for being here. And I hope we'll be able to continue the discussion. And I hope that things will continue to improve and change. And thank you so much for being here.
Thank you very much. It's a pleasure being among all of you.
On behalf of the U.S. Chamber of Commerce, I want to thank our speakers, moderators, and contributors for being a part of this important and impactful conversation today. We appreciate your insights, collaboration, and leadership. There's no doubt that there's much more work to be done, but we are proud of the progress we've been able to make and inspired by where we are going together. Today's event is a reminder that we can drive meaningful change through public policy and private sector solutions. For our chamber members who joined today's discussion, I invite you to become an active member in our EOI Health Task Force and continue the conversation on how the business community can address maternal health disparities. We know that realizing true equality of opportunity requires many voices and perspectives, and a long-term commitment that goes beyond today's dialogue. For more information on our work and how you can get involved, please visit us online at uschamber.com. Thank you for joining us today.